Good morning and welcome. It's 8:01, so we'll get started a little early on Providence time. Welcome to Medical Grand Rounds this morning. For those of you who don't know me, which I think after 18 years is inexcusable, I'm John Toohey, the Senior Director of the Providence Center for Healthcare Ethics, located here on the St. Vincent campus. And it's my privilege to introduce our speakers this morning because our Medical Grand Rounds speakers are our lecturers for our Goldman-Berlin Lectureship in Palliative Care, which we hold annually here in Oregon. And as many of you will know, the lectureship named after two physicians, Dr. Goldman, oncologist, and Dr. Berlin, general internist, whose compassionate care and patient-centered care has come to typify what we now call palliative care, so well ahead of their time. And I'm not sure if Tom Goldman, he was going to try to get here, Dr. Goldman's son. If that name sounds familiar, you're probably a sports fan for NPR. And since this is OPB Pledge Week, perhaps they've put him to work this morning. But he may be here later. And Dr. Berlin, Dr. John Berlin, his wife Carolyn are here, so we're very grateful for their presence. And also grateful that the two families allow us to use their name for a program which the Ethics Center provides. That's a great honor for us. And also grateful to their families and friends and all the donors who make this possible. One comment quickly before the introduction. As you know, very often when the Ethics Center hosts a Medical Grand Rounds, we have to end Grand Rounds, of course, at 9 o'clock. But in order to avoid the rush to everyone at the podium, for those of you who can stay from 9 to 9:30, you're certainly welcome to stay for a continuation of Q&A. So Medical Grand Rounds will be over, but the Q&A can continue. And our conversation this morning is about caring for the homeless. And those of us who live here in Portland know you don't have to do anything more than drive down Burnside going east before the Burnside Bridge especially to really get just a little glimpse of the homeless here in Portland. And a greater glimpse even now that the mayor has allowed between 9 at night and 7 in the morning in certain parts of the city, the homeless can set up their tents on city sidewalks. So more and more visible to us on the streets. But those of us here at Providence know all you have to do is visit our clinics or walk through the corridors of our hospitals to meet many of those same homeless. And they very often become the most complex medical cases, and certainly for us, the most ethically challenging cases. And it is for that reason, really, that Dr. Nick Cockler, our Director of Education, and his team, and working with Dr. Goldman and the committee, felt that this was really a topic we need to address in a palliative care lectureship. And our speakers this morning are certainly well chosen. Dr. Ann Kinderman is an Associate Clinical Professor of Medicine at the University of California, San Francisco, and is the Director of the Supportive and Palliative Care Service at San Francisco General Hospital. After completing her internal medicine residency at the University of California, San Francisco, and a hospice and palliative medicine fellowship at Stanford, she returned to San Francisco General in 2009 to become the founding director of the Supportive and Palliative Care Consult Service. In 2014, she received a Sojourns Scholar Leadership Award from the Cambia Health Foundation and was subsequently named an Inspiring Leader Under 40 by the American Academy of Hospice and Palliative Medicine. Dr. Meg Mullin studied medicine at the University of Washington Medical School, where she was also a palliative medicine fellow. She has a long-standing interest in medical care for the underserved, and she pursued this interest during her residency in family medicine at the University of Washington while training at the Community Center for Safety Net Hospital at Harborview Medical Center in Seattle. Currently, Dr. Mullin is at the Providence Regional Medical Center in Everett, Washington, where she continues to serve vulnerable populations in urban and rural Washington. Her academic interests remain focused on underserved patients and families, most especially addressing palliative care needs in the under-socially resourced adults. And so if you would please, our 2016 Goldman-Berlin lecturers, Dr. Ann Kinderman and Dr. Meg Mullin.
Thank you very much, John. Meg and I are just thrilled to be here talking with you this morning about a topic that is very near and dear to both of our hearts in the work that we've done. And we really hope to help equip you as providers in caring for people, providing really patient-centered care for folks who are often difficult to understand kind of the culture and the issues that they're struggling with. And so we're hoping to demystify that this morning. So just before I start, really, I'd love to thank, we don't have any significant financial disclosures, and I would love to thank our collaborators on this talk, which really span multiple medical centers across the country in our experience at Harborview in Seattle and the greater Seattle kind of homeless support community in San Francisco and at Montefiore, where Meg was until recently. So what we hope you'll learn today is to know more about the major challenges and concerns when you're caring for homeless patients who have serious illness. And we really want to provide multiple entry points for you to think about caring for homeless patients. So if you're an individual provider, how do you take care of the homeless patient who's in front of you? And then recognizing that our structures of healthcare are often really hard to meet the needs of homeless individuals. So what are the alternative models that are out there kind of to help better meet their needs? And then how do we think about this as a system? Because there are some great advantages to having a system of Providence and leveraging the expertise of all the different hospitals in the system. So what I'm going to do is start off first talking a bit about the background of homelessness and particularly issues that come up with serious illness and homelessness. And then we're going to dive into how to approach individual homeless patients and provide some very specific case examples of that, talk about these alternative approaches to caring for homeless individuals, and then system-level interventions for these patients. So when we talk about homeless people, I would bet that this is the image that that comes to mind. Does that resonate? This type of person who you pass on the street downtown, who's there maybe in a doorway or on a corner, and with an appearance something like this. But I wanted to really flesh out the scope of what constitutes homelessness in our country, because it is this, but it's more than this. So this is from a great resource organization, the National Healthcare for the Homeless, but it's pulled from the definitions that our government uses in thinking about homelessness. So yes, it's people who are staying on the street or in shelters, which is what people usually think about. And it's also people who are living in their vehicles or in abandoned buildings. But it's also the group of people who are living in our single-room occupancy hotels, and there are a number of those around the city of Portland who are still pretty marginal, and a lot of kind of the issues of people who are living on the street or in shelters are very much present for them, even though they are technically living indoors in their own space. And then also the people who are couch surfing, so they don't have their own permanent residence, but they're staying with family or friends, and it's oftentimes in the face of serious illness that those situations don't work anymore. So I've heard multiple patients who say, I've been staying in the living room, and they're really disturbed by seeing me losing weight or having to go to the bathroom very often or those things. And so this really isn't an option for me anymore. The other populations that I want to highlight are people who are currently in situations where they have a roof over their heads, whether that's they're incarcerated or they're actually in our hospitals and our skilled nursing facilities, and functionally they don't have a home to return to because it doesn't meet their needs. So it's not just the person who you're seeing on the street corner, but there's actually a lot larger population. And I want to talk a bit about everyone who's homeless or close to being homeless. There are different levels. So the people who are marginally housed or who are at risk are people who are living at or near the poverty line, who may be couch surfing or relying on friends for their accommodations. They may actually be able to access some of the services that are available for homeless individuals. But they're not people that we typically include. We don't count them when we're counting homeless people. People who are recently homeless, it's been less than a year, and they often don't identify as homeless. This is a temporary setback. I've lost a job. My rent went up too much, and I don't have a place to stay now. I'm going to figure out something else. But they are actually homeless. And then we hit the chronically homeless population, so people who've been without a home for a year or more, who accept that their life on the streets or in their situation is the norm for them. And that over time can lead to a bunch of other things that are important to consider around distrust. If you've had trauma or you've been assaulted or you've been someone who's passed by or spit on even, what are the things that does to you? So that's different from someone who's just become recently homeless. So I hope that in talking about that, you don't just think about the picture on the left. That when we're talking about people who are homeless, that might also be the patient that you're taking care of in the hospital now or the nursing facility right now. To take a bigger picture view of homelessness, this is from the 2014 Annual Homelessness Assessment Report, and what it demonstrates is that it is not an equal proportion across the country. There are 3 states that are kind of the highest proportions that you might expect: California, Florida, and New York. But actually, proportionately, Oregon is in the 1 to 3% category for homelessness. Getting more specific, how do we know about numbers for homelessness? For those who are unfamiliar with this, every year in January across the country, there's what's called the homeless count. And so the local communities enlist volunteers that go around on the streets and in shelters and things and count up the number of people who are homeless. And when they most recently did this just a few months ago in January, what they found is there were just under 4,000 homeless individuals in Portland. Of those 3,800 people, about over half of them were completely unsheltered. And about 900 were staying in emergency shelters. And then people who actually were housed temporarily, so this transitional housing of less than a year, which is hopefully a stepping stone towards getting permanent housing, but they're still technically homeless. Demographically, looking at this population in Portland, about 40% are people of color, predominantly male, small minority of veterans. And I highlight that because there are very prominent national efforts. And you'll hear kind of in the campaigns people talking about it's unacceptable that we have homeless veterans. So there are a lot of services and initiatives for veterans, but still over 10% of our homeless population here in Portland are veterans. The other thing that I really want to highlight is that we're seeing a trend towards older individuals becoming homeless. So there was a 23% increase from when this count was done in 2013 to this year for people over the age of 55 who are homeless. Most people had disabling conditions, and almost half were in that chronically homeless category. But what I want to highlight on the bottom there is that in addition to those 3,800 people, we estimate there are about another 12,000 that are in that marginally housed, couch surfing, at-risk population in the area. I also want to just put some pictures up around of what this looks like in Portland, of how people are managing. And I apologize. Initially, in the picture on the left, I said Tiny House Village, but it's actually called Dignity Village. And this is a group of folks who've been living in this area since actually 2000, or 2000 is when the community started, but they moved to their current area in 2004. They're currently on land that's owned by the city. And they have a very organized community structure. So they have an elected group of people who kind of determine the rules and who kind of is able to be part of the community, and they advocate as a group. There's another community called the Right to Dream 2 homeless encampment that's moved around, is my understanding. But they actually have a bi-monthly, or actually monthly radio spot on the NPR station here. So I think, when you pass by tents and things on the street, we sometimes make assumptions about who those folks are. And there's actually a much broader community and people who are working together often than you might think. Also thought it was worth highlighting that Mayor Hale's last fall, and then the Portland City Council declared a state of emergency for homelessness in the city. And what that did is that helped to reduce the legal and bureaucratic barriers to opening up more housing options for people in the very short term. It encourages greater partnership between the city and the nonprofit organizations in the city to just solve the immediate crisis of homelessness in Portland. And this, it's just worth highlighting, is happening all around the country. Similar things were passed in LA and Seattle in the last year. So with that context, I want to then hone in on what are the issues that come up when people are seriously ill and homeless. So we know that homelessness is an independent risk factor for mortality. We know that there's a significantly increased death rate in North America and Europe, and it's a wide range, as you can see, and that is because the studies are heterogeneous. It's different places in the US and in Europe. But the bottom line is that people die 20, 25 years earlier than the average American. Homeless individuals are often high users of medical systems with especially increase in emergency service access or use, and very frequent comorbid mental illness and substance abuse issues that really complicate the traditional approach of medical care. What are the issues or concerns that come up as people are approaching the end of life? Well, there's a lot of shared issues with people who are housed. So people want a respectful, compassionate presence at the time of death. And even in people who are housed, there are hospitals that have No One Dies Alone initiatives to make sure that people have companionship at the end of life. People want good symptom management. They want to have control over what's happening to them as they're approaching the end of life, and to be cared for in a dignified, respectful manner. There are also some more unique concerns that come up for people who are homeless. Oftentimes, when people are living on the streets together in community, there's actually a significant support network that comes up. And when someone in that community suddenly disappears, what's happened to them? Sometimes death has been sudden. It may be violent. It may be from an overdose or other things. And that builds up trauma over time for this community, and that becomes a norm that they experience. Homeless individuals say that they fear imposed or unwanted care, and one of the cases that Meg is going to highlight talks about this around if you don't have someone to advocate for you or speak for you or support you in decision making, and you can't speak for yourself, things can happen to you that you don't want. It's hard to have an advance directive or post form when you don't have a place that you're living in. People fear loneliness at the end of life, and particularly after death, they fear anonymity and that they're not going to be remembered or memorialized. And then there's particular fears around what's going to happen to their body or their belongings after they die in a way that's different, particularly because they don't have advocates to help with that, and oftentimes funding for it. What are the challenges that we as providers face? So we often are not very well trained in how to take care of homeless individuals, and so we feel that. We don't know exactly what to do when we're taking care of these folks. Oftentimes, we're very siloed in medicine, and so we know what to do as a physician or a nurse or a social worker, but we don't really know what's happening outside of the hospital so much. So we don't know what the resources are that are there. As I mentioned, there are patterns of, rather than kind of consistent, regular engagement with primary care, using urgent care and using emergency services in a way that can be really frustrating for providers around this person just doesn't show up to appointments. Why is that? That makes me angry. And then there are complex and unconventional needs, which I'll go into, particularly around advanced care planning. So it's very common for homeless individuals to not have a person that they can identify as a reliable, consistent surrogate decision maker. That doesn't mean that they don't have community, they don't have friends, they don't have people who know them, but those people might not have a phone. They might not be in one place where they can be findable. And that person might not be able to tolerate the pressure that comes with a discussion about, should we take this person off of the ventilator? So they don't have a surrogate that can speak for them. And then there may be mistrust of the healthcare system in filling out a formal legal document, like an advance directive or a PULSE form. What does this mean? Are you going to take away services from me? So that there's a lot of concern around that sometimes. And then even if you do, you can imagine it would be not a lot of motivation to fill out one of these forms if you don't know that it's going to reliably be communicated. You don't have a place to keep your advance directive. And then in thinking about advanced care planning, since what happens to my body after I die is a big concern, it's important to think about funeral planning, but it's often complicated about how you communicate those wishes. Then thinking about hospice care, one thing that's challenging, so the hospice benefit is only accessible if two providers agree that if the terminal condition takes its natural course, that the person will pass away in 6 months or less. Well, how do you think about someone who has, his end-stage liver disease, has a MELD score of 24, but also has comorbid substance abuse, who may die suddenly or may not take their medications consistently? It's very tricky thinking about how you prognosticate in this population. And then how do you access the hospice benefit, which is really designed to be delivered at home for someone who's homeless? So in homeless populations, often people migrate around to different areas. They don't have a consistent one place that they stay in. And you have to find a hospice agency that's really, really willing to be creative and flexible in seeing people who are staying outdoors or in shelters. A lot of times people who are homeless don't have consistent, reliable caregivers, which is one of the big requirements for doing hospice at home in the US. And then how do you keep controlled substances safe, like morphine or benzodiazepines, if you don't have a place to lock those up? So what I want to do is to talk about different approaches to addressing the problems that happen for homeless individuals when they have serious illness, at the level of the patient and the provider, the individual patient and provider, and then at the level of programs and partners, so these innovative programs that are helping to get around the barriers for homeless individuals, and then finally at the health system level. So what I'm going to talk about is just what can you do if you're a provider and you want to help the homeless patient you're caring for. I want to talk through these separate issues of you need to know the issues that are coming up for homeless individuals, ask the right questions, start planning early, identify your community partners, and then be creative. So already gone through a number of these things. What are the common concerns that come up, the common medical and health issues, mental health issues that come up, the very unique needs in this population, the limitations in our system in caring for them, and then the access to care issues. We need to ask particular questions to this population. So we don't often ask, tell me about your living situation or tell me where you're sleeping at night is a good way to approach this with someone who's homeless, is because there's a big difference in couch surfing versus sleeping outdoors. Transportation, how are you going to get to medical appointments? Is that realistic? Do you have the money to pay for bus fare? Can you get from point A to point B? And will your medical issues allow you to do that? Can you pay your medicine copays for the things that I'm prescribing for you? Do you have a phone that I can reach you at consistently? Or what are the substance use issues that this person is currently or in the past has been struggling with? Are you able to read medical instructions? Do you have any trouble reading medical instructions? What is the prior trauma that they've had both with the healthcare system and interpersonal trauma? And then what's their legal history, their active legal issues that are also weighing on their mind? I had a gentleman recently leave the hospital AMA because he had a court date that he'd already deferred a couple of times, and he didn't want that stress hanging over his head. So it's a very active issue. We want to emphasize is that we need to start planning early. So identifying the emergency contact early, identifying their goals, particular values and concerns. And what I want to highlight here is that a lot of times the abstract questions that we ask about what you hope for in the future may be really difficult for people to anchor onto. So it's oftentimes much more immediate what's happening in the coming days and weeks that someone is hoping for. If possible, completing a post and advance directive, and then identifying your community partners who can be your really key allies. So this slide really shows the incredible safety net that's often available in communities for people who are homeless, from shelter and supportive housing to mental health services, often public health nurses or outreach nurses, case managers, utilization specialists, hospice agencies that feel comfortable caring for this population, the public health department, and then, of course, all of our medical providers. What I wanted to highlight is particularly a really neat organization here in Portland called Central City Concern that has a very comprehensive approach to caring for people who are homeless, medical care, mental health services, housing, and employment training and peer support. So it's really comprehensive services. My final appeal is when you're taking care of these patients to channel your inner MacGyver and think about how you can use the resources that you have to care for this patient population. So one example that I'll provide is a gentleman who was living in a single-room occupancy hotel in our city who had end-stage liver disease and had recurrent admissions for hepatic encephalopathy in the setting of not taking his lactulose. So at the suggestion of his primary care provider, we worked in partnership with his methadone clinic to fill up a cup for him every day of lactulose. So he went in the morning and he got his cup filled up of lactulose every day and said, your goal is to drink through this slowly through the course of the day. And so he got his dose every day. We want to dig in a little bit deeper into some individual cases and show you how we walk through these issues. So with that, I'm going to hand it over to Meg.
I'm going to try to figure out this microphone. Thanks, Ann. That was great. So I had the pleasure of caring for both of these gentlemen in Seattle. Give me a second. Well, I guess that works. During the course of my fellowship, the gentleman on your left is Randy Hayes and Stanley Glover, and I'd like to be able to tell your story. I would like to preface this by saying that both of these gentlemen asked me to tell their story after they died, that part of their legacy was that they wanted people in the world to remember them and also to learn from their experiences. So Randy Hayes was at the time of this picture, a 63-year-old gentleman who had metastatic cancer. He had been chronically homeless, was continuing to use heroin occasionally. It's called chipping. You use just enough to keep you from withdrawing, and also was involved in a methadone program on and off over the course of several years. He was housed in a supportive housing group in Seattle, which meant that he had gone through a number of programs in order to get his own single-room occupancy in a building that had a nurse who was able to see him occasionally for some supportive stuff. And she noticed over the course of the year prior to me meeting him that he had been losing a lot of weight. As you can see, he's quite thin. And she was concerned about him, managed to get him to a primary care doctor who referred him for a workup and was found to have metastatic colon cancer, which perhaps could have been resectable if it had been found earlier, but as with many patients in this population, it was found quite late. He was very interested in involving himself in treatment, but unfortunately was unable to make it through the workup and appointments that would have been necessary for him to receive surgical treatment and chemo. So by the time I met him, his principal issues were that he was so thin, he was having a very difficult time making it to any appointments, and was really struggling with how to live his life in a way that was meaningful for him. As you can see, he's very attached to his guitar. He had a girlfriend who was his primary social support, who was staying at a women's shelter about 3/4 of a mile away in downtown Seattle, where all the services are located. And as he got weaker, he was unable to make the effort to go to see her. Because she was in a nightly women's shelter, in order for her to see him, she would have to take all her stuff and transport it to another part of the city. And so he was concerned that he was losing that relationship in his life. So I was asked to help out with this case, basically, to figure out how do we care for this gentleman in a respectful way, and how do we make sure that he doesn't lose more of his social support in the course of his illness. Stanley Glover is a gentleman who also was in his early 60s, who had uncontrolled hypertension and schizoaffective disorder, which means that he is a gentleman who really couldn't tolerate other humans. So he was a hermit and spent most of his time in and out of city shelters, like nightly shelters. He didn't have a consistent place that he was sleeping. But he did have a relationship with one of the nurses in one of the shelters who he took an interest in her. And she noticed, she knew that he was a high utilizer. He was seen more than 100 times in the emergency room of the public safety net hospital, Harborview in Seattle, in the previous year to when I met him, for a variety of complaints related to uncontrolled hypertension. He was admitted finally when his hypertension had gotten to the point that he had a hypertensive emergency and went into renal failure. And the way that Stanley told me when I met him, this went down, was he was admitted to the hospital, and some kidney doctor came and stood over his bed and said, "Do you want to die?" And he was like, "No." And they're like, "Great, here's your tunneled line. You're getting dialysis." So for a gentleman who was chronically homeless and really intolerant of systems and people, to do 3 times a day, or 3 times a week rather, dialysis was, as you can imagine, quite a burden. And so his nurse, who knew him peripherally, said, "I think that this is a guy that you could help." So what are the challenges facing providers in delivering the gold standard of palliative care for these patients? So if these were the medical cases that we've described, if they were in a housed individual, we have some gold standards that we would just sort of roll out, like, oh, this is what they need. They need goals of care. They need advanced planning. They need a surrogate. They need, a pulse. How is that different for these patients? And how can we manage giving them the kind of care that they need based on the challenges to delivery, as Anna's already sort of laid out? And where are their concerns different? As we've already mentioned, there are some unique needs. And what are the interventions that we can already use in the system that we have without reinventing the wheel? Like, how do we use the tools that we have to help these guys? So I just thought it would be useful to take a moment to define palliative care. I know that there are a bunch of people in our audience who are potentially learners. I know that you guys have a great educational program here. So specialized medical care focuses on providing relief from symptoms and stress of a serious illness, and the goal is to improve the quality of life, both the patient and the family. That's palliative care. So it's not end-of-life care. It's not hospice. It's actually something much further upstream. And it should be unique to the individual. So it should be meeting people where they are. It's predicated on the assumption that people have some social resources as they get sicker. And it's often based on somebody's functional status. Like, earlier in the game, we assume that you can come into outpatient visits. And, as Anne pointed out, hospice is built around the idea that you have a home in which to deliver these services. And inpatient consults often have extensive discussions when the patient isn't willing or able to talk with us. I'm thinking of somebody in the ICU, and we're talking to their friends and family. So as you can see, palliative care for somebody like Stanley or Randy is going to be a little different. So again, we're going to talk about this from a couple of different levels, from the patient and provider, from programs and partners, and from health systems. Like how does Providence approach this, for instance? So there are several models that we know of that can help modify our approach to palliative care and end-of-life care for patients like Stanley and Randy that take the existing services that we have and tweak them so that they're more appropriate. So there's a respite model. So a medical respite is a bed in an organization where somebody can go after they are released from the hospital if they have a serious illness and receive some level of support. And that ranges from it being in a shelter where most shelters will ask people to leave during the day. And this person is given a hall pass, if you will, to just stay in the building. And they don't have to leave. And all the way up to some of the programs, for instance, the RCP, which stands for? Thank you, recuperative care program that you have here in Portland, where we spent a good portion of yesterday, that have extensive social services, and in addition to medical services, to try to help people who are coming out of the hospital get back on their feet and figure out what the next steps are. Some cities have adopted a shelter hospice model, which embeds a hospice supportive care program in the shelter itself, so that as people have advancing needs as they're approaching the end of life, they have this sort of upwelling of supportive services that are available to them. Ottawa had a wonderful project that was done in 2006 that had a full-time nurse and a medical director, essentially had an inpatient palliative unit with 9 beds available in 2006 for a pilot program to see how that worked. And it worked brilliantly. Having these services available in the place where people are comfortable with a staff that knows the individual and also is well-versed in handling any behavioral or legal issues that come up to try to help support patients as they're moving through this process turns out to be a really great standard of care. San Francisco has an excellent medical respite program. And then in Toronto, there's an innovative program, which I've highlighted with this picture, that is an outreach program that goes to patients in shelter and in the homeless community in general, and it does house calls for much earlier palliative care intervention than hospice, and works with a variety of different programs in Toronto to try to help providers be educated and supported in providing earlier palliative care. And then lastly, there are volunteer and hospice integrated models that ask communities to address these needs in a much more ad hoc kind of way. One example is the Balm of Gilead, which is a volunteer organization in Birmingham, Alabama, that goes into hospitals and shelters and housing programs for patients that are identified by the community to help provide a supportive presence and an advocate as they're moving through this process, so that they at least have somebody who gets to know them and can help speak for their wishes. So I had the opportunity when I was a fellow at Harborview, which, as I said, is a public safety net hospital in Seattle, to pilot this. I learned about these different programs, and I have a background in taking care of patients who have these kinds of concerns, and put it together in my head that there was a gap in Seattle for what happens when patients are in the hospital, they're given a terminal diagnosis, and then discharged to the street. How do we follow up with those patients, and how do we make sure that the care that they get matches what they want, which is ultimately the goal of palliative care. So beautiful thing about fellowship is that they'll pay you for a year to do something. So I put together this idea of a lot of these patients, and you've probably experienced this in your own community, actually have a fair amount of support. They have a methadone clinic. They have a food bank. They have, a place that they sleep pretty frequently. They might have a primary care doctor that knows them pretty well, hopefully, if they go to Old Town. People live in the world, and if you are homeless, a great deal of your energy goes towards figuring out how to get through the day. And you have to form patterns. You have to figure out what your resources are. And in the process of that, you form community. Like you have patterns. So my idea was, how do you tap into that network? Oftentimes, I would hear from, food bank workers that they had watched this individual over the course of several months gradually losing weight and getting weaker, and thought, nobody is taking care of this guy. Nobody is aware of how sick he is, and I don't know what to do, but I'm really worried about him. And the methadone clinic had the same experience, and the primary care nurse had the same experience, and the ER doctor who had seen him 3 times in the last 2 weeks had the same experience, but none of them were talking to each other. And so what if we just got everybody together and sat them down at the table with a patient and discussed what was happening and what might come in the future, knowing that this person is going to fail. This person is not going to be able to continue living the way that they have been living. But instead of failing catastrophically, which is the model that we've been seeing, and ending up in an ICU with nobody having any idea what their wishes were, let's help them fail gracefully. Let's help them fall with some dignity and some comfort by planning ahead. So the first step would be to establish rapport, to take an excellent history. As Anne had said, you have to ask specific questions. You have to ask, where does this person sleep? Who constitutes their family if they don't have a family in the way that other people would expect? And be able to assess, align, and adapt barriers and concerns. Okay, so just because somebody is insecurely housed doesn't mean that they all have the same concerns. As Anne highlighted, there are very individual specific concerns. They might have legal concerns, they might have immigration issues, they might have very complex family situations. It's very important to sort of think ahead, like how would it go? Like if I was going to be thinking about what to do with this person's effects after they died, and realize that they have a street family that's been helping care for them, but they don't actually have a will. How do I get stuff out of a storage unit and dispersed to the people that they would want to have those things, as an example? You need a good palliative care assessment. So what are their goals of care? What are their advanced care planning needs? So do they need to have a pulse form filled out? Do they need to have a durable power of attorney filled out? Are they a person who would never tolerate being in the hospital? And if so, how do we meet that need? So figure out who the important people are, and then invite them to the table. And the way that I did this was literally inviting them to the table, but locating the care conference in the place that the person slept most often. So in their community. And most of the time that was in a day room or in a shelter or in subsidized housing. I was unable to include people who were truly unsheltered and sleeping rough because of the limits of my study, but it would be not unreasonable to do that as well. And locating in that place turned out to be a very important part of caring for these patients in a respectful and dignified way, not just because it showed to the patient that you were willing to go where they lived, but also because the providers, all of the various members of their team, gave them a much more realistic outlook of what the physical layout looked like. And so as we were planning, it became much more practical. Devise a plan. And then repeat. So every plan is sort of hopeful, right? I think anyone in medical care can realize that it's somewhat fantastical to make a plan. When that plan doesn't work out, you continue to repeat. So it's an iterative process, basically. So we did this with Randy, and his specific issues were that he was concerned about money. He had hawked his guitar, which was the love of his life outside of his fiancée, and how to maintain that relationship. His medication access, so being able to get to the methadone clinic every day was obviously not working anymore. We live in a state where medical marijuana is a reality, and that was an important source of support for him. And being able to stay in his own place. This was the first time that he was in a single room occupancy, and it was the first time that he had had a locked door in his adult life. So for his pain needs, we transitioned, thinking out of the box, the MacGyver. This is the MacGyver stuff, right? As a team, we transitioned, we planned to transition from the methadone program to a pain model. So it's illegal for physicians or providers to prescribe methadone once daily unless you are a member of a methadone treatment program. However, methadone is a great drug for treating malignant cancer pain. And so we planned to transition when he was no longer able to manage getting to the methadone clinic every day to transitioning to treating his malignant cancer pain from his metastatic colon cancer on a several times a day basis, which is a reasonable treatment option. And the way that we set it up was we asked Randy to tell us several days in advance, like, when you think it's getting to the point where, like, wow, it was really hard to get up and out of bed today, to give us a heads up. And so he was able to give us 3 days warning. We got it all together, and we transitioned smoothly. Simple as that. It just took planning ahead. We gave him an alarmed lockbox, and the reason for this was, even though he had a single room occupancy, there were concerns with the staff about his ability to manage his own meds, and if he had guests, what that would look like. And so having a lockbox meant that his nurse who filled the lockbox and Randy were the only people who had access to it, and it was alarmed so that it went off and reminded him when he was supposed to be taking medication. We gave him frequent scripts and a very small number of tablets. So he had the hospice nurse and the building nurse checking in with him every day or so and filling the box so that he never at any time had something that was going to be easily portable from his room and disposable. So the lack of social support, the housing unit asked for and received I'm losing it. He was able to move the fiance in to become a caregiver, even though it was a single room occupancy. Most of the time, these housing units are extremely rigid about who is allowed to stay where, as you can imagine. So this took about 4 months through various levels of bureaucracy to get her to a place where she was able to be the primary caregiver for him, and she was willing to do it, which was a big bonus. But to Randy, this was the ultimate win. I also was incredibly grateful and lucky that I had a hospice nurse who was willing to provide the level of support in a kind of shaky social situation, and was willing to go there both physically and philosophically to give it a go and just see what happened. And so having those kind of community partnerships is incredibly important. So the financial concerns. So you have the opportunity to work with a payee in this community, in many communities. So if somebody is unable to get to the bank and manage their own affairs, you can have somebody designated to do that for them. And since marijuana was a pretty important thing to Randy, one of our staff members contacted one of the local medical marijuana dispensaries who decided out of the goodness of their heart to provide medical marijuana to Randy free of charge and delivered it. It's amazing if you ask what people are willing to do. So part of Randy's process from a palliative perspective was doing life review. So he got his guitar out of pawn, which was incredibly important to him. And the hospice organization was able to provide an iPad to him to record his life story. And as I mentioned, he asked me to tell you his story because he wanted to be remembered and he wanted his process to help inform other patients. And his fragmented care that over the course of time he had not been able to coordinate getting chemotherapy or radiation or surgical treatment of his cancer because of his inability to make it. We utilized this process to form a care conference, and the palliative care outpatient clinic was able to be the answering service, essentially, for all of these community providers to coordinate care. So Stanley Glover, this is a portrait of me that he did as we move forward with his story. So he, over the course of several meetings with him. In my initial encounter with him, I was introduced to him by his nurse. I sat down with him, and he's very tangential, and he managed to, at one point, look at me very pointedly and say, "Don't you patronize me." And I was like, "I will definitely not do that, sir." He really needed to have some kind of a sense of locus of control. He had started dialysis. It was not working for him for a variety of reasons. He was having a lot of symptom management issues. And so establishing rapport for him was an absolutely essential thing. His goals of care, we discussed over, as I said, several visits, and he finally was able to tell me in really clear language that he was not interested in receiving further dialysis. And so then it became a challenge of how do we figure out how to help this gentleman die from renal disease without dialysis in a totally unsheltered situation. So we had to put together a professional family. So we collaborated between the shelter, the medical respite, the hospice, and a hospital to have this graduated level of care. We knew that after he stopped dialysis, he was going to have a period of time when he could get about his business and everything would be fine. And then gradually he was going to have more and more burden of symptoms and was going to need more and more support. And he also needed to do a lot of end-of-life processing. And once we sort of took that burden away from him of what's going to happen next, and we were like, "Listen, Stanley, we're going to take care of this. And when you need more, we'll move you into a new situation. We're going to take care of this." He was able to do a lot of life review on fast forward. He started drawing portraits of people around him. He'd always been an artist, but he suddenly became engaged with people. His high-utilizing social worker, who had had a relationship with him for years, took him down to the Pike Place Market every day for 3 or 4 days, and he drew portraits of every person that would sit still long enough. He wanted to get in touch with his estranged children. We reached out to them using social media. One of his nurses posted a message on Facebook and managed to get in touch with one of the daughters who lived back east, who had totally lost track of him. The family didn't have any idea where he was and hadn't had contact with him for 10 years. And they managed to put together a reconciliation. So from a systems level, what I found interesting is, yes, these are 2 cases. I had 36 cases over the course of a year that had similar kinds of outcomes. And it's great. It's heartwarming, right? You know, we did a lovely thing for these individual patients. But how does this affect us on a systems level? And what my study found was that there were a lot less no-shows for clinic appointments when people actually were engaged with care and had a supportive environment. Stanley never went back to the emergency room. Remember, he had more than 100 ER visits in the year before. Less days in the hospital at end of life. Randy had been in the ICU several times over the course of his care prior to having these care conferences. Never went back to the hospital. Never needed to go to an ICU. And really, the biggest finding I had was that there's a tremendous amount of moral distress, and I'm sure you can relate to this. Caring for these patients is really difficult, and it often feels that you're the lone voice in the wilderness, you know, recognizing that this is challenging. So I wanted to touch on something else that Anne mentioned, after death. So what happens to people after they die when somebody is alone? So there are indigent burial programs. They vary considerably. There's a concept called Potter's Field that comes from, it's actually a biblical reference, that the place to bury people was where there was a lot of clay deposits, and so it was an agricultural land. And we use that term now to refer to a place where we bury people that we don't know what else to do with them. There are a lot of low-cost funeral planning. I want to highlight particularly this program, dfsmemorial.com. If you Google it, it has it's state by state different programs that can help families that are dealing with this issue. So for Randy, there was a community charity program that provided cremation costs, and his girlfriend received his ashes. And then there was a memorial at the building where he had lived for the last couple of years, so that his community had a sense of being able to mourn for him. And for Stanley, we located his family, and they were able to come out and pick up his body. And I met with them and was able to go through his story so that they could know what happened to him and that there was a community caring for him at the end of his life, that he didn't just die. Also, they were able to get his art from his storage unit. He had been not paying for medicines, but paying for a storage unit, and where he had dozens of paintings that he had done over the course of years and years. So again, talking about this from the different levels, we've been able to talk about it from a patient and provider perspective with these patients, the programs, the varying models for adapting palliative care and end-of-life care for patients who have special needs, and from a health systems perspective, being able to highlight if we do it the right way, that we can actually make things a lot better, both financially and from a moral and ethical standpoint. So what can you do? There are state programs that can help with leveraging partnerships in the community, like with Care Oregon and Old Town Clinic, that can really provide more comprehensive care. There are QI initiatives that you guys can do in your own practices. Like when you notice patients like this and you're concerned that an outcome didn't go the way it did, how can you make it better? How can you anticipate these care needs coming up for another patient in the future, and how can you adapt your practice? And advocating and innovating. So when you do see these things, speak up. So I work for Providence. I am new in this role. I am the medical director for the inpatient palliative care program in Everett, Washington. And so Providence has a unique opportunity. It's a regional network. It's, as you know, Alaska, Washington, Montana, Oregon, and California. There are 34 hospitals in the network, and there are palliative programs in all of the hospitals. And did you know, I just learned, there's a monthly conference call for the Palliative Care Network that shares all of these issues. So you all have a resource available. So if you identify your local palliative care champions, when you come up against these problems of like, how do I provide respectful palliative care to a patient who has unique social needs, you have an option to be able to tap into a resource. So you can help educate other providers. We provided a handout and that you hopefully picked up on your way in that has some clinical pearls in the back. Take that back to your team, put it up somewhere, hold on to it in a place that you can find it, and if you find it useful, refer back to it. You can develop strategies for improving transitions. Transitions are really where these patients fall through the cracks. I think that Portland is doing a great job advocating for access to care and continuing that process. And if you're interested in this, we really need research. This is a dramatically understudied area. And as we discovered yesterday, partnering with payers like Care Oregon, extremely useful in being able to anticipate and plan for services that are definitely going to be needed in the community. Don't forget the big picture. Ultimately, what's important is caring for these patients and being able to remember their humanity, and even in the smallest ways. So, how are you going to change your practice? Hopefully, having listened to this talk, you're going to get grounded in the relevant issues, your eyes opened a bit. Start asking questions of yourself and other people, questioning your assumptions about what kind of care is appropriate and how do you deliver that care. Becoming more aware of your community partners, particularly in Portland, where you have such a rich community environment with resources. And then asking yourself how Providence is going to be responding to these patients, particularly in the era of an ACO and increasing Medicare and Medicaid enrollment. More and more patients with more social needs are going to be coming across your doorstep. So how are you planning on responding to this? So that's our talk. I want to thank the families of Stanley and Randy for allowing us to talk about this and share their stories. Especially the University of Washington Palliative Medicine Program for providing support for this work. And of course, Providence for inviting us to speak about this.
CME time anymore, but education is valuable for its own sake. So, questions for our speakers? I mean,
So it's not really a question, it's a comment, but I gotta tell you, was a hospice nurse for 12 years, and now I work here in inpatient palliative care, and I kind of came here with a grumpy attitude. Your presentation was outstanding.
Oh.
You nailed what it's like to be homeless in the community.
Oh,
Thank you.
Thank you.
Thank you.
I'm sorry you were grumpy, but I'm glad we fixed it.
Yeah.
But you're right. It was outstanding. The
Thank
information
you.
was great. Thank you.
Yeah.
I also have a comment. I work in outpatient palliative care here in town. I know Providence has a program, and they work with people who are not insured necessarily, and then I work with Adventist, who's contracted with Care Oregon to provide for the Medicaid, Medicare population. And I like what you have to provide here, and I think doing more collaboration and outreach is really important. So I just wanted to say thank you.
Yeah.
Yeah. I think a lot of times what we've discovered is that a lot of times there are actually a lot of resources, but as Meg highlighted, they're just not connected. And so I think that is one really key role that we can do, is just bringing people together. And I think, when you listen to the cases that Meg went through of Randy and Stanley, it's kind of mind-blowing, right, about what they were able to accomplish. And that was like Meg, one person, working as a fellow, but just connecting the dots, making it happen. So I want to just say, I hope that you don't walk away going, that was this pie in the sky thing that couldn't be done. It was one person doing it, connecting and tapping into the resources that were already there.
I have two questions. First of all, how many hours did it take you and your staff to coordinate one of those patients?
It's hard to quantify. So a great deal of it was done by email and telephone, quite honestly. The care conferences themselves were usually about an hour, so kind of what I would expect for a palliative care consult. In terms of, really it was a lot of virtual work over the course of time. And the face-to-face work with, like for Randy, for instance, was largely done by his nurse and by the hospice community, so that it was part of their pay scale. The number of consults, to be real, I did a needs assessment over the first sort of half of the year, and then opened enrollment in January and closed it 6 weeks later because I had already reached my maximal number. I exceeded it, actually. And so over the next 6 months, I had 36 patients that I had a total of 123 visits. So it's a full-time job. Each individual patient, though, I would say that what it really took was attention. Like, it just took some timely emails. The activation energy wasn't that great. It just required knowing who the key players were and reaching out to them. People were eager. This is the thing that totally surprised me about this. I thought that I was going to be herding cats, right? I thought nobody's going to come to these things. I'm going to end up, trying to replicate the same thing over and over because people aren't going to have time in their schedules. But what turned out to be more true was that everybody felt a profound sense of moral distress about these patients and desperately wanted to do something about it. And when I offered them the opportunity to get together and had the opportunity that people could phone in if they couldn't get out of clinic, made it easy for them. People were quite eager.
So if you were going to hire a staff member to work at this full time, what would be how many patients do you think they could manage in 1 year?
So that's actually being tested out. So what I didn't say was the pilot was successful, and Harborview applied for a HRSA grant, HRSA grant, and the work is continuing in Seattle. There's a nurse practitioner and a nursing case manager who are continuing to do this work, and the goal for them is an active enrollment of about 50 patients a year. And they've continued to sort of have the narrower margins, unfortunately, that I needed to impose in order to be able to manage that number of patients without the full backing of a clinic or a full team. So again, not being able to do things like doing outreach behind a 7-Eleven. I would love to be able to get there, but that is definitely 2.0. And so Tony Boxwell, as the nurse practitioner who's doing it, is connected through the supportive housing community and shelter system and their aim is about 50 patients a year. And sometimes it's a one-off. You just meet the patient, and you're pretty clear about how to help them identify a surrogate, for instance. And sometimes it's like, Randy and Stanley, that were obviously a much more detailed and in-depth interaction.
Thank you. Second question is that I noticed that 2006 Ottawa project you referred to in past tense.
Oh, yeah.
And it's a problem with all pilots, is that how do you get it sustainable? And now that we have the benefit of, or encouragement to save money, do you think that you can show that you save enough money for the system in order to support a staff that deals with 50 patients per FTE?
So, yeah, I mean, so I think, if you look at these cases, that Meg was highlighting of Stanley having 100 emergency department visits in a year, you can pay for a lot of FTE with just one person, right, that you're caring for. So I think that the challenge that I experience as a program director in palliative care is that, and especially working in a complex city-county kind of arrangement, is that the bucket where the cost savings are realized is not the well that we can draw from to hire a staff person, but is a really compelling argument because it is all one system that's actually responsible for the care of these individuals. And I think on top of those kind of rational financial arguments, I think that this really speaks to the moral distress piece of the ED providers who are seeing this person 3 times a week, it's just really draining. So I feel like the argument can be made around these patients in our system from a financial perspective. The thing that's challenging once you get out of the hospital, so that's an argument you can make to the hospital, right? To say, this person's coming into our system, we're not getting compensated for a Medicaid patient, nearly as much as we're spending. So it makes sense for us as a hospital actually to pay for these 2 nurses to make the program go. But when you get into the community and you say, can we set aside shelter beds for this purpose? Can we create a different structure? Can we find all of these partners? That becomes more tricky. And is why I think the models sometimes are pilots that then don't go forward. But I think that what's encouraging to me in San Francisco is we start to think about how can we take better care of the folks who are in our single room occupancy hotels, who, as Meg was talking about, I mean, can you imagine if you had been living for 20 years or 25 years on the street, and you'd never had a secure place to call your own. You never had a door you could lock and have privacy and some level of security. What it would feel like to have your own bed, Just try to. I mean, it's unfathomable to me. I've never been in that circumstance. And you finally get housing. You finally get into one of these hotel rooms, and you get hospice services. And then 2 weeks later or 4 weeks later, the nurse who's caring for you says, you're too sick to care for yourself anymore. We need to move you to a higher level of care. Can you imagine the resistance you might feel to leaving what is now your own bed and your own space? And this happens all the time. So what we're thinking about in San Francisco is how do we really boost the support for these people who are living in our single room occupancy hotels, who are getting hospice services, so that they can stay in what's become their home and live as they want to live for as long as possible. It's probably not going to be possible until the very end of life, but it might be possible for longer. So, and when in the process of trying to develop that, I was talking with one of our hospice partners, and there was a woman who said, "Oh yeah, we tried to do that in Marin County in the early the early 90s with folks who are marginally housed in Marin, and it didn't work. It was a pilot that then didn't go forward." And to me, I also living in the Bay Area, we're the land of startups. And they say, like, if you haven't failed, I don't trust you with my money. So I take that as we need to learn from what didn't work about that. So we had a phone call with that person that said, what were the things that worked about that model? What were the things that didn't work? Who is actually at risk financially in this situation? And figure out how to get buy-in with those folks and make compelling arguments for them. So I'm, I feel like working with vulnerable patients, you have to kind of have a streak of maybe irrational optimism sometimes to keep going, keep at it. But it's really exciting to think about really supporting people and providing them that dignity and the care kind of. It's just the difference between the soul-crushing feeling of people who are not getting the care that they need and providing this beautiful patient-centered kind of end-of-life experience is something that it fuels that perhaps irrational optimism.
And to that end, what's the alternative? Is it acceptable to us as a community that we don't have a plan for how people are going to die? It's from an ethical perspective, and certainly, being in an institution that is mission-driven, it is not acceptable that we don't have a plan. It might not be a great plan, and we might need to work on it, but we need to have a plan. It needs to be addressed and discussed and acknowledged.
I'm the medical director for the Providence Health Plan, and am responsible for our Providence Medicaid members here in the Tri-County
Thank you for
area.
coming.
Well, thanks. It was a great talk, and we've had some case conferences that we've been able to get the members to. We've met in the primary care provider's office, but they've been a whole lot better if you can get the member to show up. And I really like your idea of going out to where the member is. We'll have to see if we can pull that off. So,
Great.
But my question was, you mentioned the monthly palliative care conference. Do you have? I'd not heard of that before, which is kind of typical for Providence. There's all kinds of cool things going on that you never hear about.
Yeah.
So, any idea who to talk to about who's doing that?
I'm happy to provide that information, Justin Burkhoff.
Okay.
Oh, go ahead. Yep.
Were you talking also about the networking call?
Yeah.
Yeah, there's somebody. Rhonda, do you want to speak to that?
Well, you're going to provide the contact. Here. I'm Rhonda Williams. Hold on. Be sure you Thank you. My name's Rhonda Williams, and I'm the Regional Director for Palliative Care here in Oregon and oversee the Connections program in the Portland area. It is a monthly networking call. It is organized by the system-level palliative care group, and the contact person is Justin Bronkhorst. And you're going to pass that information forward in terms of the contact information. And it's a 7:30 Monday morning meeting. I forget which second Monday of the month. Interesting speakers covering all kinds of different topics. And additionally, we have Tina Pickey here in the audience, who is with the Supportive Care Coalition here. We're lucky to have her here in Oregon, but it's also a national organization that provides all kinds of educational opportunities available to all of us here in Providence. Do you want to say anything more about that?
I just want to say thank you for coming, and we had a chance to talk, initially, and I'm just so pleased because this was such an excellent presentation, and I would really love to have the opportunity for you to speak to our national audience. So I'm going to be talking with the both of you at some point.
Fantastic. Like I said, I am so just encouraged that this is a topic that you all wanted to highlight in this really important venue, because I think that it's fascinating to me, the issue of homelessness, the stark visibility of it in some ways around, so I live in San Francisco, and we just had the Super Bowl, right? And there was a huge controversy around the homeless individuals who were living near. So the Super Bowl wasn't even in San Francisco, right? It was down in Santa Clara, down in the South Bay, but we had Super Bowl City up in San Francisco, where people came for like a week to celebrate the Super Bowl. Who knew? But so they closed off a number of streets that were right kind of on the water, and there were places where some of our homeless community stayed. And there was this huge controversy around these individuals being asked to move or relocate to different places. And we have places where people have set up tents that have then been cleared out by the Department of Public Health. So in part because it's kind of an eyesore. People don't want that to be an image of our city. So it's incredibly visible on the one hand, but it's also incredibly invisible. And the thing that really is interesting to me as a healthcare provider, when someone is hospitalized, that there's this leveling of the playing field when you put someone in a hospital gown, that in some ways really dehumanizes them, right? The CEO of a company and a homeless individual have the same fears and concerns around what's happening to me and things like that. So it's often, you don't see it as much as the person who you pass on the street who's sitting in a doorway. But so there's good and bad to that. I mean, I think it's really interesting, the leveling of the playing field, but it also makes us forget that that's an issue that we should be thinking about and asking about.
So I really love the idea of this model, and especially with healthcare reform, really thinking about coordinated care very intentionally. But I'm also curious how you were so successful in really getting everybody to come together, especially, I think everybody has this same idea of reducing stress and very much around service for what's best for the patient and individual or client, however, whatever language we're using. But, sometimes social service world, like in food banks and everything, we have kind of different language to speak about these things. We all have kind of different metrics or measures we're using. And so how did you kind of balance those factors to still be so successful with the coordination that happened?
I asked. It's real simple. I Googled the food bank and I called them and I said, do you have a supervisor who's usually there? And they said, oh yeah, that's Mike. I said, can I talk to Mike? And I said, hi, I'm Dr. Mullin and I'm taking care of Randy Hayes. He gets his food from you pretty frequently. He's a tall guy, super skinny. And he was just like, oh yeah, I know. I was just like, so I just wanted to reach out to you and let you know we're putting together a care conference and Randy gave his permission to include you since you're a big part of his life, since he gets his food from you. And he was just like, when is it? I really can't emphasize how surprising and delightful it was, how much interest there was in helping contribute to the care of these people who they saw, on the regular, but had no way of helping. So don't underestimate, the power of just picking up a phone and just asking.
And I think the thing that's beautiful to me is I feel like with these individuals that oftentimes have had a history of trauma and have a history of mistrust, what I find is that they're different providers who have different pieces of the story. Mm-hmm. So I would be willing to bet money that gentleman from the food bank knew these interesting and important anecdotes about Randy through the years that then when you come together can kind of make more of a whole in a way that is healing for providers. And I think one of the really neat things that Meg was doing also was including the person, the patient, the client in those care conferences.
Absolutely, centered around
that. And so they're getting to see very visibly, physically, this whole network of people that really cares about them and brings their story together and acknowledges their story. So I think it's healing in and of itself. I'm curious if there, for you guys who are, healthcare providers who have stuck in there, 80 minutes in, what are the kind of the challenges that you guys are facing that we might be able to help with problem solving, troubleshooting, things like that?
So I find it more in the hospital setting, the discharge planning can be really hard because we're so concrete in the hospital. They need a place to go. No, they can't just be homeless. What are we going to do? And in helping to, again, think outside the box and encourage, people have the right to make choices about where they want to live. And we just have to figure out what we can offer. So that I find that patients tend to stay here longer because I think of our discomfort as a healthcare system about where they're going to go.
Yeah. Are people, have you heard about the recuperative care program? Yeah, okay. So just to explain for those who haven't heard, I am totally new to it as of yesterday, and fill in where I'm wrong. So it's actually a place in downtown Portland that actually provides short-term housing for people who are hospitalized, homeless, and need more care, kind of to support, to get hooked into the medical system, the mental health system. And the people stay there on average somewhere between 1 and 2 months usually. And they have their own room, their own locked door that gets stocked with food. There's an incredible staff there that addresses in a very patient-centered way that person's needs and their barriers to care. Will actually physically walk them to Old Town Clinic and help them get in for the services that they need. And the thing that I want to highlight is that it's not a one and done situation. They see people actually frequently and actually feel like when they see people on a repeat basis, they can move things forward, kind of the bigger picture forward in their relationship with those folks. And they'll actually come to the hospital and start discharge planning before they'll meet the client, meet the patient, actually come and pick them up on the day of discharge. It's really neat. I'm jealous.
Yeah, big time.
Can I just follow up on that? At, excuse me, statewide Kinsman Conference, which was 2 weeks or so, I guess, one of the things we talked about were the competencies of the homeless and the mentally ill. And so very often what we think is a very dangerous discharge, the question is it safe enough for us? Because we don't have the competencies to make it work, but they do. And so very often seeing what they can pull off is not always what we can pull off, and we have to be sensitive to is it safe enough, because it is really safe.
Good point.
And I did want to mention, depending on the circumstances, the health plan will pay for that too.
For
them to stay
recuperative
there.
care.
Yeah, for a month or two. So
Yeah.
we do cover that.
Well,
cost,
and it
so,
makes
yeah.
sense from a financial standpoint. From a financial standpoint, it's foolish not to, because the hospitalizations are so profoundly expensive, and if you're staying in the hospital because you have no place else to go, Providence has a financial interest in trying to help support people.
I'm curious, I do work with a lot of individuals where they finally have a place, and then I'm, trying to look down the road of what they might need. So what was your process? You said it took 4 months to allow his girlfriend to be the caregiver, because that's what I've run into. Like, if I'm trying to keep them where they are, allowing anybody to stay and provide some caregiving.
So that's a good point. And the reason that it took so long was because it was, I think, a novel ask. And so it was like, oh, well, I can't give you permission for that, but you should probably talk to my boss. And then, I think we need to actually sit down and talk about this as a group. Like, what's the precedent? And is this going to inform the rest of the community? And, how is this going to be a process going forward? And, it's just business as usual, right? So it took 4 months because it required several meetings with people who are very busy. Ultimately, I think everybody's heart was in the right place, and they asked very good questions. As with all of this kind of care, if you don't have a team where everybody is in agreement about the plan, it's not going to fly. So you can't ignore people's questions or objections and not reasonably accommodate them if you have any expectation of being able to make it work now or ever again. So I was very mindful of being extremely cautious about not alienating any stakeholders and getting everybody's concerns out on the table and addressing them in a really transparent way. So that took a little time, but it worked.
The thing that I'll also highlight in that is that you know, it's not for no reason that these hotels have these restrictions. You know, bad things have happened when they allow people to stay in groups or, you know, whatever in these small spaces. However, the thing that I'll say that's counterbalancing that is particularly for people, some of these hotels have had people for 10, 15, 20 years. And for them to be able, they really want to support people who are part of the community to be able to stay there as long as possible. And so I think that gauging that and, you know, kind of how they're feeling about this person as part of the community and how they affect the community. I mean, because so in these hotels, there's like your neighbors down the hall or the people, they're like kind of looking out for each other, you know, and so what that means to allow people to die in their home is actually huge. And so I think highlighting that maybe and saying, you know, like we would really love to support this person to die in their community and for not just this person, but the staff and for the community.
So on that, I'm going to thank all of you for staying on, and Ann and Meg, thank you very much.